You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is July 18, 2016, and I'm your host, Dr. Jay Portnoy. Our topic today, rhinitis. Our presenter is Dr. Mark Dykowitz. He's the Raymond and Alberta Slavin Endowed Chair and Chief of Allergy Immunology at St. Louis University School of Medicine in St. Louis, Missouri.
This morning, our speaker is Dr. Mark Dykowitz, and he is going to speak to us on rhinitis, a primer for specialists. Rhinitis is something that allergists and allergy fellows will see a lot. Dr. Dykowitz is from St. Louis University, coming to us over the COLA network. Dr. Dykowitz, please go ahead.
It's my pleasure to be with everyone this morning. Thanks again for offering me the opportunity to talk to you about, as you indicate, a very common disease that we deal with, and we want to do it right. Looking at my disclosures, there we go. Nothing really is relevant to the presentation. Our objectives are to better distinguish between allergic and non-allergic forms of rhinitis and also review key differential considerations. Also would like you to be able to better select treatments for both allergic and non-allergic rhinitis. And then as we get more evidence bases for using combination therapies to better understand the evidence for using, or in some cases not using, combination therapies for rhinitis. First, we'll talk about definition. It's a very important problem, rhinitis, that we'll talk about. I do want to distinguish between different types of rhinitis that are out there. Again, review differential considerations, but spend then time on diagnosis with a lot on treatment. Well, by definition, guidelines have come to the point of saying that rhinitis is characterized by one or more of the following symptoms, and the four key symptoms are nasal congestion, rhinorrhea, which could be anterior or postnasal drip, sneezing, or itching. Now, inflammation is implied by the itis in the rhinitis term. However, realize that inflammation is present in allergic rhinitis, but not in all types of non-allergic rhinitis, which actually comprise a lot of patients walking into the office. Overall, allergic rhinitis is the sixth most prevalent chronic illness and maybe the most chronic condition in children. And as you see, it's a highly prevalent disorder in both adults and children, with estimates varying to range there. It's also important to treat rhinitis and recognize it and deal with it because of its comorbidities. And there is some evidence that appropriate management of rhinitis can be an effective component of management of coexisting or complicating respiratory conditions. And this includes asthma, sinusitis, and sleep apnea. There's also tremendous cost, both because of direct medical costs, but also indirect costs to society because missed school and work. And actually, speaking about missed school or work, we're not just talking about absenteeism, but also presenteeism. That is to say, people show up for work, kids go to school, and they're there, but they're really not functioning at a good level. And if you see in this figure, the mean productivity loss per employee per year for, on the left-hand side, allergic rhinitis versus a lot of other medical conditions, allergic rhinitis is right up there. So a tremendous impact on society. There are several major rhinitis guidelines. One of them I have been very involved with is co-editor with Dr. Dana Wallace. The last full publication was in 2008. We are currently working on a revision that we hope to have at least a focus document completed even in the next couple of months. Then there's the allergic rhinitis in asthma guidelines, which is predominantly European-driven, but does have representation from people all across the world. There recently was, in 2015, a guideline that was a consensus document. It was published by the American Academy of Otolaryngology Head and Neck Surgery. I represented the QuadAI, Dr. Wallace represented the ACAAI, and it is focused purely on allergic rhinitis, but it does also give up-to-date recommendations on the allergic rhinitis aspect of the broader scheme of rhinitis. So, our major categories of rhinitis are allergic, non-allergic that we're going to talk about, and then the reality is people can have mixed problems with both allergic and non-allergic rhinitis, and it is estimated that roughly a third of the patients walking into offices would have pure allergic. Some, one-third would have non-allergic rhinitis, but another third might have components of both allergic and non-allergic rhinitis. This slide and the following there are from a table in the Joint Task Force Practice Parameter on Rhinitis. It shows you the panoply of different types of rhinitis that can occur. I only show this on this presentation to have you recognize there's a lot out there. There are also, as we'll talk about, nasal symptoms that can be associated with inflammatory and immunologic disorders. To start right off with allergic rhinitis, this is, of course, IgE, allergic antibody-mediated. Common allergic triggers include pollens, and in most temperate climates, you're seeing a seasonal pattern versus some other allergens, including indoor allergens that can give you year-round problems. Molds can be a problem both year-round. In fact, there at Children's Mercy, the research was done that was showing that in house dust, molds can be present on a year-round basis. Now, this does get into the whole use of the term seasonal, perennial, what we call episodic environmental, intermittent persistent, and occupational. So there's a little bit that should be said about those different terms. I would say that using this example that we already gave about pollen, the grass pollen, in the Midwest, that would definitely be a seasonal problem. But if you're talking about some warmer climates where there isn't frost, you could see grass pollen actually causing perennial allergic rhinitis problems. Now, why should we try to classify allergic rhinitis by different characteristics? Well, this is one way that you can better define the subpopulation for conducting clinical trials, but also it really assists you in the selection of the most appropriate treatment for an individual patient with allergic rhinitis. So you can classify allergic rhinitis by the temporal pattern in the context of exposure. We've already talked about seasonal versus perennial. The Joint Task Force introduced the term episodic implied environmental rhinitis, where you have episodic exposures to allergens that normally aren't in your environment. Let's say you normally are not around a cat, but you have to go to a relative's home that has a cat, and you're allergic to the cat. You would have episodic environmental allergic rhinitis in response to the exposure to that cat. Also, there is the discussion of frequency of symptoms. Now, the ARIA guidelines have defined this most specifically, and they use the term intermittent, which is less than 4 days per week or less than 4 weeks per year, versus persistent, where you have more than 4 days per week and greater than 4 weeks per year. This isn't perfect, but it sometimes can give some sense as to the types of medications that you might choose for the patient when you would give them. Also, in talking about mild versus more severe rhinitis, essentially more severe rhinitis is when symptoms are beginning to interfere with quality of life, including sleep impairment, impairment of activities in school and work. Now let's talk about non-allergic rhinitis, for which the nomenclature is variable. So let's go into some of that. Well, first of all, just to set it aside, we certainly could state that if somebody gets a viral upper respiratory infection, that is some acute infectious non-allergic rhinitis. But in the context of what we're seeing for patients walking to our office, most commonly these are somewhat more persistent chronic disorders. If you look in the big scheme of things, as I've already alluded to in a previous slide, maybe 1/3 of the patients with rhinitis across the board have non-allergic problems. So there are a couple terms: perennial non-allergic rhinitis, PNAR. Another one we'll talk about a little bit more, vasomotor rhinitis, and idiopathic, and depending on which guideline you're looking at and tradition, one or other of these terms may be used. There's also a subset of non-allergic rhinitis which has eosinophilic inflammation of the nose, and that's nares, or non-allergic rhinitis with eosinophilia. And in fact, the problem about defining different categories of non-allergic rhinitis is pretty vexing. There was an NIAID workshop conducted several years ago, and the aftermath is still leading to some further definition of terms. It's not an easy consensus approach that's been established yet. So for perennial non-allergic rhinitis, also known as vasomotor rhinitis, also known as idiopathic, you don't have eosinophilia. There typically is a less favorable natural course. Patients tend to be somewhat more resistant to treatment. Symptoms can vary depending from the individual, from obstruction to congestion to rhinorrhea. Now, versus allergic rhinitis, you're less commonly going to be getting a patient talking about sneezing, nasal itching, or eye symptoms in non-allergic rhinitis. The term vasomotor rhinitis merits a moment to talk about. Sometimes that is a term that's been used synonymously with non-allergic rhinitis without eosinophilia, but sometimes there is this connotation that nasal symptoms are being provoked by non-allergic factors. Now, in fact, even though it says vasomotor, there is not a clear understanding that this has anything to do with vasculature, but nonetheless, the vasomotor rhinitis terms might imply that acute changes in the external environment are causing rhinitis symptoms. That could be sudden changes in ambient temperature, walking in or out of an air-conditioned building in the summertime, exposure to odors or irritants such as perfumes, passive cigarette smoke exposure. Alcohol, by virtue of its vasodilatory effect, does in fact have some, if you will, vasomotor underlying cause of rhinitis. And then there are other factors, including exercise, sexual arousal, and emotional factors that can play a role as well. Now, the FDA these days is now viewing the importance of trying to define different subsets of patients with rhinitis that have these types of triggers, with the idea being just because something might be of some benefit in a patient who is predominantly bothered by ambient temperature changes doesn't mean it's necessarily going to be a treatment that's going to help people who are bothered by odors or irritants. A few words about non-allergic eosinophilic rhinitis, or nares. This, in different studies, can be up to 1/3 of patients with non-allergic rhinitis. Anosmia is very common, and the patients are more likely to have more severe symptoms than other types of non-allergic rhinitis or allergic rhinitis. So some patients will evolve on to having nasal polyposis and aspirin sensitivity. Typically, there is good response or a notable response to intranasal corticosteroids. I should also mention an entity called local allergic rhinitis, sometimes referred to as nasal entropy. It's been reported that in some patients you can get local IgE production, but without evidence of allergy as assessed by doing skin testing or in vitro blood testing for IgE. The patients in the studies have been defined as having positive nasal allergen challenges. There's been some suggestion that these patients might also have a basophil activation test to allergens, but this is actually one of the issues that the Joint Task Force Rhinitis Work Group that I'm co-chairing is dealing with, because we really need to have larger multi-center, well-controlled studies in both kids and adults to better define how prevalent this is, the natural history, and how to best diagnose and treat it. Let's put it in here for completeness at this point. We don't know what to quite do with it practically. I do want to mention food-induced gustatory rhinitis, which is rhinorrhea occurring immediately after food ingestion. It's a cholinergic process. Hot, spicy foods might be more likely to cause the problem, but for some patients it can occur from any food. You can also define the nasal congestion after drinking alcoholic beverages as a form of gustatory rhinitis. One thing that is very important to keep in mind is that IgE-mediated food allergy as a cause of isolated rhinitis symptoms. It really is rare if it occurs. If somebody has food allergy, they should be having other manifestations of a food allergic reaction than simply rhinitis. Other important rhinitis syndromes to keep in mind would be those that are drug-induced. Very commonly, we will see patients who have rhinitis medicamentosa, where they, if you will, have become addicted to using topical nasal decongestant sprays. We'll talk a bit more about that in a few minutes. Cocaine can also cause that. Some people will have rhinitis symptoms with aspirin and non-steroidal anti-inflammatory drugs, particularly in older populations where ACE inhibitors are commonly prescribed. You should keep in mind that patients can have nasal symptoms of both congestion and rhinorrhea. They do not need to know, or they do not need to have cough. ACE inhibitor-induced cough, of course, is quite common, but there are plenty of patients out there that will have more isolated nasal symptoms without cough, and that should be kept in mind. Other medications, including beta blockers, antihypertensives, and oral contraceptives, can promote rhinitis. You should take a good history, therefore, to see what medications the patient is taking to see if they might be having some component of medication-caused rhinitis. And then speaking of hormones with oral contraceptives, there are other hormonal disorders, including hypothyroidism, pregnancy, particularly during the last trimester, and women during menstrual cycles can see variation in rhinitis symptoms. Also, there is a clear entity where GE reflux can be so severe that it actually can get into the nasal mucosa and cause rhinitis. Speaking a bit more of rhinitis medicamentosa, this occurs with ongoing use of nasal decongestant sprays and results in the downregulation of alpha adrenergic receptors. Basic treatment would be to use intranasal corticosteroids, but you sometimes have to bridge the treatment of the patient with a burst of oral steroids to get the edema down so that the patients can, if you will, get off of their addiction to the nasal decongestant sprays. What you have to keep in mind, though, is evaluating why do they get hooked on nasal decongestant sprays in the first place. Do they have some underlying chronic rhinitis, allergic, non-allergic rhinitis? Or sometimes what you'll see is somebody doesn't have any pre-existing history of rhinitis. They catch a cold, they start using the nasal decongestant spray, and then they just never seem to be able to get off of it. So take a history of whether it had a very acute onset with that type of a context. There also are a number of structural and mechanical factors that can mimic rhinitis, and that could include deviated septum. Usually a deviated septum will cause unilateral congestion, but you can see almost S-shaped septal deviations that can result in bilateral congestion. Hypertrophic turbinates, particularly inferior turbinates, can be responsible for nasal symptoms. And then there are other differential considerations, including adenoidal hypertrophy, foreign bodies in children, kids putting peanuts in their nose, but also be mindful that there can be nasal tumors and choanal atresia. Nasal polyps certainly can present with nasal symptoms that could be confused with more standard run-of-the-mill rhinitis. You should also keep in the back of your mind the entity of cerebral spinal fluid CSF rhinorrhea, which is typically unilateral. If somebody came to you talking about unilateral rhinorrhea, you should think about this right off the bat. It can occur post-traumatically, but it may occur spontaneously. One thing that can be done diagnostically looking at the nasal discharge is for the presence of beta-2 transferrin, which would not be present in nasal secretions. You can also check the glucose levels, which would be akin to what you would see in CSF. And then there are other serious systemic disorders that can cause nasal symptoms, Wegener's, sarcoid, lupus, Sjogren's, and I won't belabor those further. So you're taking a history, physical exam is being performed, you are doing allergy testing if indicated, and then looking at the diagnosis, sometimes with additional diagnostic testing. So in taking a history, first of all, ask, what are the bothersome symptoms? Is it runny nose? Is it nasal congestion, sneezing, or itching? And again, the presence of itching would steer you away from thinking this is non-allergic rhinitis. Asking about which symptoms are important can also be important for deciding which treatments to use. Some treatments are better suited for certain symptoms. Also ask about associated eye symptoms such as itchy, watery red, or swollen eyes. Again, as I mentioned, these associated eye symptoms are more common in allergic than non-allergic rhinitis. We've already talked about trying to identify the pattern of rhinitis, whether it's seasonal or perennial. That could have implications as to when you're treating patients, as well as what type of diagnosis you're giving them. And it is of value, I think, to figure out how infrequent or frequent are the symptoms, whether there's episodic environmental exposures that are causing problems, because there are different medication strategies that can be used for these different types of rhinitis. You should be asking about effects of home versus school or work, so you should take detailed environmental history. Whether there's a greater problem outdoors, which suggests outdoor allergens, versus indoors, which suggests indoor allergens. And then you ask about acute symptoms with house dust mites, molds, cutting grass. Is actually a good mold question because you are disrupting the molds at the bases of the blades of grass and getting them aerosolized. And, of course, acute exposures with pets. Good question to ask, especially relative to the pet story, is if a patient does have a pet in the home and they go away on vacations and they're better away from the pets, that is some evidence anyway that the pets are a significant problem. Of course, you're going to also ask whether people have problems with food, gustatory rhinitis, and again, review drugs that they're taking. With ACE inhibitors, for instance, it is something that just similar to ACE inhibitor-induced cough may not happen right away, and it could develop after the patient's been on it for quite some time. Specific points of history to consider would also be in terms of the nasal congestion. Normally there should be shifting of blood flow from one side to the other every 4 to 8 hours, so-called nasal cycling. So if you have a patient who is saying that they have predominantly one-sided congestion, you should be thinking about an anatomic cause such as a septal deviation. There could be nasal polyps or other problems too. I'll ask, of course, about if the patient's already taken medicines, what was their response? And especially in this day and age, we now have nasal corticosteroids over the counter as well as oral antihistamines. Ask what they've taken. Figure out whether they really gave it a fair shot. It wasn't just a spray or two and then they gave up the ship. And then make an assessment from there whether you should be going to a different type of a treatment or maybe in terms of, let's say, a nasal steroid, just enhancing the adherence and giving instructions on optimal use. I think one of the more common differential considerations is sinusitis. Certainly in some patients you can get a story that there'll be an acute onset of nasal symptoms with thereafter persistent symptoms after an upper respiratory infection, and that would be suggestive. Now, of course, you can ask about things like headache and purulent drainage. that might increase the likelihood that sinusitis is present, but even the destruction, the decomposition, if you will, of the eosinophils from allergic rhinitis in the nasal mucosa can lead to purulent-looking drainage. So that's not a be-all or end-all. You should be asking about the presence of coexisting conditions such as asthma, sleep apnea, or acid reflux. And, of course, the family history of allergic disorders would increase the likelihood that the patient sitting in front of you has allergic problems. Actually doing the physical exam, looking at the nose, pay particular attention to the septum. Is it deviated? Are there any mucosal ulcers or erosions, particularly in the septum? Look at the turbinates. Are they so swollen that spraying a nasal spray is not going to get anywhere? And the patient may need, if they're going to go that route, a short-term use of a nasal decongestant spray or sometimes oral steroids. Also take a look at the mucosa and the mucus, whether it's purulent, but again, as I've just mentioned, that doesn't necessarily give you a clear clue about whether it's allergic, non-allergic, or infectious. Obviously look for nasal polyps, and because there's a lot of connectedness to the nose, also take a look at the eyes, the ears, the oral pharynx, and examine the lungs because of the high prevalence of concomitant asthma. Specific IgE determination, of course, can be very helpful. It can be done either by immediate type skin testing, which we generally prefer, or in vitro tests. And knowing if somebody's allergic or not can assist in the selection of different pharmacotherapeutic options, some of which have no value if the patient ends up having non-allergic rhinitis. Also, it can help identify specific allergens, so that can lead you to giving some directed, focused allergen avoidance measures, or when appropriate, prescribing targeted allergen immunotherapy. Now, in the big picture of treatment, we're looking at avoidance measures, environmental control measures. House dust mite covers avoiding pets. I think that's covered in other lectures, so I'm not going to belabor that more. So we're going to focus more today on pharmacologic therapy, but in context, we must also remember that allergen immunotherapy can be an important component of optimal treatment of allergic rhinitis. So looking at different pharmacologic therapies, as you're going to decide what to prescribe the patient, think about what type of rhinitis is present. Is it allergic, non-allergic, or mixed? Is it seasonal, which might make you think actually timing the medications to begin even a week or so before the anticipated allergy season? If patients are having more frequent symptoms versus intermittent symptoms, if it's infrequent intermittent symptoms, you would probably want to choose an agent that has rapid onset of action that the patient might end up using on a PRN basis, whereas if there are more persistent symptoms, even an agent that has a slower onset of action may be a better bet if it ends up being more effective with already alluded to the fact that depending on the type of symptoms the patient has, you'll choose different medications. So if nasal congestion is a major problem, generally speaking, an oral antihistamine or a leukotriene receptor antagonist are not going to be great choices. A nasal steroid, for example, or an intranasal antihistamine would likely do a better job with congestion. In terms of severity, here again, if you've got more severe symptoms, you would not be using as monotherapy an oral antihistamine or a leukotriene receptor agent. You'd be ramping up, if you will, to the intranasal preparations. And also, there are considerations that come into play with children. I mean, children may be less likely to tolerate nasal sprays. We'll talk about issues of growth with nasal steroids in children, which in contact is not a huge concern, but it's something that has to be considered. And then senior patients are more likely to get into adverse problems with certain medications, particularly sedating oral antihistamines. That has to be kept in mind too. All right. A little slow responsiveness here from St. Louis. One thing I would commend to you is to look at the Joint Task Force Practice Parameter on rhinitis. There's one particular table where we've tried to distill different therapeutic considerations for different treatments for rhinitis, and it's a quick and easy way, particularly for recently starting fellows, to get up to snuff about understanding the nuances of different treatments. And there also was some effort, even though it was 2008, to try to put together what are the evidence, or what is the evidence basis for different combination therapies. All right, let's go through the different monotherapies. Generally speaking, intranasal corticosteroids are the most effective medications for allergic rhinitis. Keep in mind, although a number of medicines help for both allergic and non-allergic, if you got non-allergic, you're not going to get significant benefit with oral antihistamines, oral antileukotrienes, or nasal chromones, so they shouldn't be used. And then combination therapy should be considered when symptoms aren't fully controlled with monotherapy, but as we'll discuss, combos aren't always better. Some combos are more effective than others. As you prescribe intranasal preparation, keep in mind a few basics. Just don't prescribe it, but give the patient instruction on how to avoid spraying medially towards the septum, which might cause erosions or even in rare cases nasal septal perforation. And then, because some people will complain about the so-called drippage of nasal sprays, and for certain preparations, the perception of adverse taste, in our clinic, we often will talk about bending your head down in a nose-to-toes technique to try to reduce that type of problem, and we tell people to stay in the down position for 20, 30 seconds before they stand up. They obviously administer the sprays while they are in upward direction. I think it's also good clinical practice to have the nasal septum periodically examined for mucosal erosions. In our clinic, every 6 to 12 months after patients have been initially seen, we like to have the patient back to take a look at the nasal septum, make sure that that looks okay. And as we've already talked about, for intermittent or infrequent allergic rhinitis or episodic environmental rhinitis, you'd like to choose an agent with a rapid onset of action. So that brings up a question. According to the Joint Task Force, which of the following agents is not recommended for a patient with episodic allergic rhinitis? So your choices are oral antihistamine, intranasal antihistamine, intranasal corticosteroid, or oral antileukotriene. And the answer is oral antileukotriene for the following reason. If you look at the onset of action with different medication classes, leukotriene receptor antagonists start kicking in by the second day, whereas you see the other examples there, you can get much quicker relief of symptoms, and those would be better suited for rapid onset in that context of a patient. In terms of nasal steroids, again, they are generally the most effective monotherapy. They also have particular merits in patients who have nasal congestion. They can be used on a somewhat PRN basis. There was one study that looked at more than 50% days used, but still PRN. You can then decide whether that was PRN or not, but that was still found to be significantly more effective for seasonal allergic rhinitis than placebo. Nasal steroids are generally, as monotherapy, more effective than a combo of oral antihistamines and leukotriene receptor antagonists for allergic rhinitis. And the onset of action in comparison to intranasal antihistamines is less rapid. You can see some improvement within 12 hours, even a couple hours, 3 to 4 hours, but oftentimes it's a week or two before you get into full benefit. So they could be considered for episodic allergic rhinitis. Interestingly, For relief of associated ocular symptoms, nasal steroids are every bit as effective as oral antihistamines. Also, nasal corticosteroids can be useful for non-allergic rhinitis, and so if you have somebody who's got both allergic and non-allergic triggers, that could be an appropriate choice for use. Local side effects of nasal steroids are generally minimal, but as I've alluded to, you can get into problems. Nasal irritation and bleeding is probably one of the common problems. Proper technique of avoiding the septum is important, and as I mentioned, there are rare cases of nasal septal perforation. Systemic side effects in adults are not significant. In children, there is no HPA axis suppression, but there are some concerns relative to growth. It depends on the product. It depends on the type of methodology that was used. Much of the data is reassuring. However, the FDA was reviewing several years ago over-the-counter status for nasal triamcinolone, which is now approved, and they were looking at some decrease in mean growth rate. So as a class, the labeling for nasal corticosteroids for over-the-counter use says that the growth rate of some children might be slightly slower, and if a child needs to use the spray for longer than 2 months a year, the parent should talk to the child's doctor, with the idea being looking at possible alternatives to use or possibly even monitoring for growth in the context of using the nasal steroids on an ongoing basis. Okay, oral antihistamines, very commonly used. They may be appropriate for PRN use because of the rapid onset, but a couple key points. One is the guidelines are all pretty consistent with avoiding first-generation sedating agents. This is not just because people can get subjective perception of sleepiness, but people can have performance impairment that they don't even sense. That can be, for instance, in the case of driving, every bit as impaired as you could get with being inebriated, legally drunk with alcohol. Also, first-generation antihistamines can lead to disturbed sleep architecture. So even though people may sleep for X amount of hours, they actually may not have the same degree of rest that they would otherwise. And then there is a problem with anticholinergic effects, not only in particularly men with urinary retention, but a new concern that's been having more focus, and that is the risk for dementia from the anticholinergic agents used in seniors. So diphenhydramine, for instance, was implicated as being associated after 3 years of use with an increased risk of dementia. Decongestants come in oral and nasal forms. The oral forms, I have to keep in mind, for pregnant women should be avoided because they can increase the risk of gastroschisis if administered in the first trimester of pregnancy. Also, patients can be vulnerable to hypertension. Some people just don't sleep as well with them. They can have more anxiety. One thing to keep in mind in this era of behind-the-counter availability of pseudoephedrine versus what's available over-the-counter phenylephrine, the evidence for effectiveness is much greater for the pseudoephedrine. But, of course, because pseudoephedrine can be used by illegal methamphetamine labs, we have that restriction on the availability of pseudoephedrine. Relative to nasal decongestants, these are generally going to be more effective than the oral decongestants and do lack many of the cardiovascular and CNS side effects of oral decongestants. But nasal decongestants, as we talked about, can be associated with tolerance and rebound rhinitis medicamentosa. I would put as an aside, though, that there are several major studies recently that indicate that if you concomitantly administer a nasal steroid with a nasal decongestant, you're much less vulnerable, at least for a several-week period, for developing rhinitis medicamentosa. Talking about intranasal antihistamines, these, in a comparative way, are less effective than nasal steroids for nasal symptoms. But as they say these things, in terms of, generally, more commonly, we're talking about average responses. You have to keep in mind that there is some heterogeneity to rhinitis, just as there is with asthma, and for certain patients, they actually might do better with an intranasal corticosteroid, or an intranasal steroid rather than an intranasal corticosteroid. Nasal antihistamines do have clinically significant benefits on nasal congestion, probably more so than oral antihistamines. Nasal azolastine has an FDA indication for non-allergic vasomotor rhinitis. These agents also have the merit that they are rapidly onset with their action, so they could be appropriately used for PRN use. Major side effects are sedation and taste perversion. I do think the nose-to-toes approach that I mentioned earlier can gain better patient acceptance by reducing the adverse taste perception. This is just a meta-analysis that shows you what I just told you, and that is you're comparing on the left the nasal steroids versus on the right the nasal antihistamines. By and large, the nasal steroids are more effective. Oral anti-leukotriene agents are convenient to take. They're oral, approved down to age 2 for montelukast for seasonal allergic rhinitis. The statement is made that the efficacy is similar to antihistamines, but usually the caveat is that this is with loratadine as the usual comparator. Although the Joint Task Force in 2008 said that this could be an agent that would be considered when treatment can benefit the upper and lower airway, other guidelines are not so positive about the role of leukotriene receptor antagonists. In fact, the 2015 AAO HNS guidelines said that clinicians should not offer oral leukotriene receptor antagonists as primary therapy for patients with allergic rhinitis. And that looked into risk-benefit considerations, also cost considerations. Also, there have been reports that montelukast is associated with neuropsychiatric events, and that has to be kept in mind as well in the prescribing of these agents. In terms of this, yes?
Sorry, just a question. On the neuropsychiatric events, is that more like behavioral changes in kids, or can you see things in adults?
You can see problems in adults, and I've seen anecdotally patients who are prone to depression that seem to be more depressed on it. So I think it's across the board. You could see it in kids. The greatest concern probably was raised in adolescents, where there seemed to be increased suicidal ideation in some adolescents. But I think it's a potential problem across the board, although I don't think it happens very commonly. We just have to keep this in mind.
Okay, thanks.
You're welcome. Then we have intranasal anticholinergic agents, of which we got one in the U.S., ipratropium, which comes in 2 strengths. The 0.03 is for allergic rhinitis, whereas 0.06 is for acute URI usage. This can be very effective for reducing rhinorrhea, but really doesn't do anything for other symptoms of allergic rhinitis. You also have to keep this in mind in your back pocket, though, because it can help reduce rhinorrhea from non-allergic rhinitis. It's dosed every 8 to 12 hours. There is very rapid onset within 15, 30 minutes. So if you had somebody that was prone to having gustatory rhinitis and they were going out to dinner with friends and didn't want to have social embarrassment from having a runny nose, you could have them take just 15 minutes before ipratropium to reduce the rhinorrhea that might occur. And again, because it is a rapid onset agent, it can be well suited for episodic environmental rhinitis or intermittent rhinitis that just comes up out of the blue. I'm trying to advance the slides, but they are not advancing.
Let's see if oh, you got it.
Okay, here we go. Intranasal cromolyn is our last medication. This, I think, has its greatest role for episodic environmental rhinitis, where just administering it even 15 minutes before allergen exposure can protect the patient for 4 to 8 hours against allergic response. In contrast to use this for maintenance treatment of allergic rhinitis, and certainly it's a very safe drug. So, in pregnancy, you would actually have very good safety considerations for its use. The onset of action is kind of slow, and also it might take even 4 or 6 weeks with ongoing use before you see full benefit. So it's, I think, really more of a kind of a niche medication. Now, which of the following would be appropriate for treating non-allergic rhinitis? We've got a choice of oral antihistamines, oral antileukotrienes, nasal cromolyn, or nasal ipratropium. And really, of those, only the nasal ipratropium would be of likely value. Oral antihistamines, oral antileukotrienes, and nasal cromolyn generally are effective only for allergic, not for non-allergic rhinitis. And for non-allergic rhinitis, what we do have that can be of benefit is the nasal corticosteroid class, nasal antihistamines, and nasal ipratropium for selectively the rhinorrhea. Now turning to combination therapy. So we'll start with the question. In a patient with seasonal allergic rhinitis, not controlled intranasal corticosteroid monotherapy, addition of which of the following has the best evidence for improving symptom relief? An intranasal antihistamine, an oral antihistamine, an oral leukotriene receptor antagonist, or an intranasal cromolyn? Well, the answer is the only one that really has good evidence is the addition of an intranasal antihistamine. I think this brings up the point that very commonly we're often recommending people take nasal steroids along with oral antihistamines. However, if you look at across the board mean responses, it's difficult to demonstrate that there's any better benefit for rhinitis symptoms with the use of a combination approach with oral antihistamines and a nasal steroid as opposed to monotherapy with a nasal steroid. So this is actually one question that we're dealing with on the Joint Task Force now, and there's a proposed statement that we might soften a bit, but based on the evidence we've got, there is not any clinical benefit to adding an oral antihistamine to an intranasal steroid, at least for most patients. Incidentally, the Joint Task Force Rhinitis Work Group is working with the evidence-based medicine group there at Children's Mercy, and they are really an integral, very appreciated part of the process of looking at the literature that's available. Now, the combination of an intranasal antihistamine and a nasal steroid has been shown to lead to better improvement than either agent used as monotherapy. There is a combination nasal product that is available. Of course, you can also prescribe a separate spray with a nasal steroid and a nasal antihistamine, but then you get into an issue about having to wait between sprays so that everything just doesn't drip out. I tend to tell people, and this is just based on my experience, try to wait about 10 minutes before taking your second spray. And then if you're talking about a patient with mixed rhinitis, conceptually there can be significant added benefit of the combination of both a nasal antihistamine to a nasal steroid, with the idea both of those as monotherapies can be of benefit for both allergic and non-allergic rhinitis. This just shows you one particular study which looked at mean improvement in total nasal symptom scores over the course of the study. And so obviously the higher the number, the greater the improvement, the better the result. And you see there with the data in circles that you lead to better improvement than using monotherapy with the square data, which is the nasal antihistamine, versus the triangle plotted data, which is the nasal corticosteroid. How about the combination of an oral antihistamine with a leukotriene receptor antagonist? This is kind of a weak situation. The last practice parameter iteration said that this could be used as an alternative treatment for patients unresponsive to or not compliant with nasal steroids, and I think that's still a reasonable consideration. However, if you look at studies that try to compare monotherapy with each of these agents versus combined therapy of an oral antihistamine and oral leukotriene receptor antagonist, you don't see a good, consistent superiority with the combination therapy. And certainly the combo of those two oral agents is less effective than even monotherapy with an intranasal corticosteroid. I'm going to skip by that one, which just demonstrated what I just showed you, but I want to get done in time here. So, got now a patient with negative skin test to aero allergens. They've got year-round rhinorrhea, but no significant complaints of nasal congestion. Nasal ipratropium gives some but inadequate relief. Is there evidence basis for adding a nasal corticosteroid? And the answer is yes. There can be an additive effect of intranasal ipratropium and an intranasal corticosteroid on rhinorrhea. Here we see one study that was looking at the mean duration of rhinorrhea throughout the course of then it was actually the number of days during the course of treatment that people were experiencing rhinorrhea. And in a comparative way, you're looking up at placebo up on the top with the open circles, then ipratropium in squares, in triangle, a nasal corticosteroid, and then down in the diamonds, the combination of the two, which led to a better result. So in terms of a thought paradigm, when your symptoms aren't controlled in a patient, whichever medication is first selected should either be considered to be switched out, substituted, or, if appropriate, added to something else in a combination regimen, which, of course, hopefully is a regimen that has some demonstrated additive benefit. Now, this sort of is, I think, one of the key slides of the presentation, and this is what I'm going to end with, because, you know, in this day and age, people often have come into us, kids and adults, with trying over-the-counter medicines. We're talking about they've tried oral antihistamines. In many cases now, they've tried nasal corticosteroids. Or maybe you're seeing them in follow-up. You made a nice, very thoughtful, selected prescription of medications, but they come back and they say they're still having problems. Well, first thing to always check about is, are they actually complying with therapy? And this is true for, of course, any medical condition, but it's particularly true in rhinitis because studies show that compliance adherence rates are not very good in a lot of patients. Also, are they using the medication effectively? I mean, maybe they were taking a nasal steroid, but they were squirting it in, it was immediately dripping out, and going over some techniques on how to get better retention of the preparation in the nose may lead to better benefit. Of course, you're then going to have the dilemma if the patient's not doing well. Do you switch to a different medicine or with a monotherapy, or actually step up to a combo therapy? You should also keep in mind, are there unaddressed triggers or environmental factors at play? I mean, if the person is allergic, for instance, to pets, and the pet's still in the home, that's going to reduce the likelihood that you're going to get great benefit from treatment. Also be mindful that there could be alternative or comorbid diagnoses. That could include rhinosinusitis, acid reflux as examples. You would ask, therefore, about heartburn, just one question. Then you would also want to know if there are anatomic issues, septal deviation, turbinate hypertrophy. You know, sometimes your next step might be to give another go at another round of a medication approach. Other times, even at that juncture, maybe the second visit, you might look at the need for doing further diagnostic studies such as rhinoscopy or ultimately CT sinuses. If a rhinoscopy would be appropriate and you don't do it, then you should consider referral to somebody who could, such as an otolaryngologist. Also, for things like inferior turbinate hypertrophy, there are surgical reduction approaches that can be used to reduce partially the inferior turbinates that can lead to good improvement in nasal symptoms. You have to keep that in mind. And then, of course, for allergic rhinitis, always consider the possible role of allergen immunotherapy if patients aren't improving as they should. And although I know Dr. Nelson is or will be presenting another lecture on allergen immunotherapy, there also would be an indication for allergen immunotherapy for patients who are doing well but want to reduce their long-term requirement for medication. So that's the end of my formal presentation. We have a really tip down right after that. My experience is when you tell people to do other positions to actually apply the spray, you get in all sorts of convoluted positions that don't work, and so I try to keep it simple, spray while they're upright, but then right after that, dip down.
My second and third question relate to therapy. So based on the practice parameters and what you've discussed, is it recommended that non-allergic rhinitis be treated with nasal ipratropium as your first-line monotherapy, or is it steroids? And the second question refers to saline irrigation. I noticed you did not mention that, and I wonder if that has a role.
Well, the last question's easy. Yes, saline irrigation can have a role, and of course there are different types of commercial products, devices that can be used. I might as well mention like Neomed and Sinus Rinse and Netipots. And people, particularly if they got a lot of mucus, can get some good benefit with that. A key point to keep in mind is if they're going to do that, they should do that before they start spraying in all their pharmacotherapy into the nose. And I usually talk about people after using the saline rinses of waiting maybe about 10 minutes or so for them to drip out everything before they put in the intranasal preparation. The other thing in terms of non-allergic rhinitis, most patients with non-allergic rhinitis are going to be giving you several different symptoms, not just rhinorrhea, but potentially congestion. And for that, using a nasal steroid or a nasal antihistamine would be probably more first line. On the other hand, there are some people that are predominantly bothered by rhinorrhea, and if that's the case, you could make a case of just using ipratropium monotherapy as a first-line agent. So you really sort of have to tailor it to the patient and the particular symptoms that they are being bothered with their non-allergic rhinitis.
Thank you.
You're welcome.
I think we have a question online. I think that you mentioned a study describing the association between dementia and oral antihistamines. Are you less likely to recommend oral antihistamines because of this?
The important distinction here, and I was going to try to see if I can get back to that slide, is first generation versus later generation antihistamines. That is to say, the dating antihistamines, here we are, that have anticholinergic side effects along with them. The newer agents, such as, for instance, fexofenadine and the whole context of everything, maybe they're not that new, but things like loratadine, they don't have significant anticholinergic effects, and they have not yet been identified to be an issue relative to this dementia concern. So this is looking at that slide specifically for sedating first-generation antihistamines that have associated anticholinergic effects, and it's thought that the anticholinergic activity is what's being associated with the dementia. So that's the key point there.
All right. Well, I see no other questions. Thank you very much.
Thank you.
Thank you.
Dr. Dykowitz, and hopefully things will be not quite as warm in St. Louis as they are in Kansas City today.
You should get your better. All right.
Well,
Good day.
thank you. Good day.